Hi, everyone. The Deputy Director, Country Program, Country Representative at FHI. He oversees the infectious disease and global health security portfolio. So, Abby, feel free to introduce further yourself, and then you can kick off our session. We just changing the order of the speaker as while we're waiting Emmanuel Agogo to join us on this webinar. So again, welcome everyone, and the floor is for you, Abby.
Thank you. Thank you very much, Professor, and thank you for the opportunity. I will activate my camera to introduce myself, but I will have to remove it because I don't have a very good internet connection. I am Ebi Bile. I'm a public health lab specialist with over 30 years of experience. And my experience actually is mainly in low-resource countries. I have worked extensively on HIV/AIDS, tuberculosis, and emerging infectious diseases in Africa and the US. My primary focus includes developing and implementing diagnostic systems using diverse diagnostic tools, strengthening disease surveillance and lab diagnostic network, and building lab capacity, policy development, and program management. So again, thank you, and it is my pleasure really to share with you this important presentation on optimizing the lab cascade for Mpox surveillance, access to testing and care in Africa. Thank you. So like I said, I will deactivate my camera to improve the communication. Thank you.
Thank you, Abby. And I see Dr. Emmanuel Agogo has joined us, so we will follow up as the second speaker. Thank you.
Through my presentation, I'm going to take you through the current Mpox situation in Africa. Give you an overview of what is Mpox, what are the different strains that we have. And then we'll go through the lab cascade concept. What is a lab cascade and how can you optimize those lab cascade strategies really to improve diagnostic capacity and surveillance in the resource-limited country, mainly in Africa. And then I will also take you through some new strategies that we can actually use to improve Mpox diagnostic and surveillance. And then in 2 slides, I'll share with you some support FHI work that on Mpox diagnostic in Africa. So Mpox remain a significant public health issue in Africa. That one we all know is with the rising cases.
Abby, I got a request. You need to put your slide on slideshow mode. It's not yet. You need to click at that icon at the bottom. Yeah, that one.
It is.
Yeah.
You can't see it. Okay, let me change it and see how. You still can see it?
Abdon, is that okay?
Can you see it?
Not yet, Professor. It's not in slideshow.
Okay, let me change it and see how we can improve it. Sorry for that. Let me remove my. Let me disconnect this. Give me 2 seconds.
Yeah.
Okay. Can you see it now?
You need to reshare your screen.
Okay. Share my screen. Is it fine?
We can read, but something is not working. But in interest of time, maybe we can just keep going.
Again, apology. That's why I say my network connection is a bit weird. So, like I said, Mpox remains a significant public health concern in Africa. And we have observed notable increased cases in fatalities over recent years. According to WHO and CDC Africa, from 2022 to July 2024, more than 37,583 cases were identified with a bit more than 1,451 deaths. In 2023 alone, we have an increased case by 78.5%. And in mid-2024, there were 14,250 cases and 456 deaths. The Democratic Republic of Congo is the hardest hit. According to for most cases and death, with also some cases observed in other countries like Cameroon, Central African Republic, Congo, Nigeria, and South Africa. For an overview of monkeypox, here the monkeypox belong to the MpoxReC family, which consists of a double-stranded DNA virus that infect both human and animals. And the notable members include several genus, but the one that we're interested here is the orthopox virus, which causes disease such as smallpox, monkeypox, and vaccinia. But we also have other genus such as parapox virus, yatapox virus, and mollustic pox virus that also encompass for other diseases. One thing that we should all keep in mind is that according to the data and WHO, the monkeypox was actually eradicated globally by 1980 through vaccination efforts. So we should all keep that in mind. So talk about emerging diseases. Monkeypox is a zoonotic disease classified as an orthopox virus, closely related to the smallpox. It is a DNA and have two main clades, clade 1 and clade 2. It can be transmitted from human to human through close contact, including sexual contact, contaminated objects, and from mother to fetus during pregnancy. Animal to human transmission occurs through contact with infected animals, hunting, trapping, and although the natural reservoir remains still unknown for now. The incubation period for the Mpox ranges from 5 to 21 days, and during which an infected person does not exhibit symptoms and is generally not contagious. What are the main challenges that we have when we face an Mpox outbreaks? We know in Africa, it's generally the same challenge that we have across the continent. And the major challenge that we observe in many countries include lab testing and confirmation. We usually have inadequate lab infrastructure, trained personnel, limited access to reliable diagnostic tests, and under-resourced healthcare systems. We also observe delays in confirmation cases, and this is due to inadequate sample transportation and processing times. You also have inefficient data management that lead to under-reporting, because the major challenge we have in our setting is that once the samples arrive in the lab and it's testing, it takes time for the lab actually to send back the result to the patient or even to the surveillance team. And one other major challenge that we shouldn't forget is the vaccination. Remember, we said that in 1980, Mpox was eradicated through vaccination. Vaccination distribution is a challenge, and actually availability and distribution due to logistical challenges, especially in remote areas. And additionally, competing public health crises divert resources. I can give you an example here in Guinea. We are facing right now about 5 to 6 concurrent ongoing outbreaks. So when we have this kind of situation, it's really difficult to manage with the infrastructure and the structure that we have available in the country. Optimizing the lab cascade strategy. It involves enhancing steps of the diagnostic process to ensure timely and accurate results. And those strategies include mainly the lab infrastructure. We already talked about a couple of, and equipment. The training of lab and healthcare professionals. The availability of enough adequate stock of reagents and supplies and diagnostic tests. And the sample transport. Actually, this is one of the major problems where we will spend a bit of time when we get to the following, to the next slide. And then lastly, we talk about the data management challenges that is also we face in our continent. So here, this table shows you about kind of the sample collections steps. This is the pre-analytical phase of the lab diagnostic.
Ebi, your slides are not moving. We still are at the first slide, so something is really wrong.
Oh, okay. You are, which slide are you at? You said the first, the outline?
No, you are at the map, the current Mpox situation in Africa.
Oh, that's strange because, okay. So
there seems, yeah, now we are second. Yeah.
So when you see that way, you can see the map moving.
Okay, now it's moving.
Okay. Okay, we saw that. We are at the, okay, can you see this slide?
Yeah.
Sorry, apology. I will have to remove the presentation mode because that's what created the confusion. So
try again slideshow just in case to see if it works better.
Okay, let me try again. Okay, can you see?
No, it's not working on our side, but that's fine. Yeah, just go back to the.
Yeah. Sorry for that. So we'll move with this. This is the pre-analytical phase. This actually table show you the different steps that need to be taken at the pre-analytical phase in order for the lab to optimize his testing capacity. First, we need to have a good test request. And usually in case of outbreak, we talk about notification form. So that notification form needs to be correctly filled with all the required information. We need to have a patient and specimen identification on the tube, correct one, that is the same information on the notification form. And we have to have the correct specimen collection and make sure that biosafety and biosecurity safe measures are put in place and followed by the healthcare professionals to avoid any infection. And use specimen transport medium, since we are dealing with a virus, to ensure that the samples is well kept and have the appropriate documentation. And to do that, we really need at the pre-analytical phase to really give a comprehensive training to the healthcare workers, meaning that from the person who collects the specimen to the lab on proper sample collection. Secondly, we need to develop procedure on sample collection to minimize variability and errors. And the key part is the transportation. We need to establish a protocol and efficient logistic plan for safe and timely specimen transport, and provide cold chain infrastructure such as cooler boxes, temperature monitoring devices, and also make sure that the lab staff are trained on sample reception and logging into the system. So here we have the type of samples that are collected and that need to be collected for a good diagnostic to make sure that results are accurate, and the different materials that are used for collection, the temperature of during the transportation, the type of test that is required for these samples, and for a long-term storage, the temperature that is required. As you can see, we have various sample types. Goes from skin lesion, blood, urine, and saliva collection, and they are transported usually at 2 to 8 degrees. We need to make sure that this temperature is followed during all the transportation. And for a long-term storage, the lab need to have at least a freezer with -20 or -80 capacity. As you can see here, the PCR tests are commonly used for detecting viral DNA, and it is used as the gold standard as defined by WHO and CDC. We also have some additional tests like genome sequencing that help track virus mutation, real-time PCR tests like GeneSpect or the COBA MPXV that provide rapid results. For example, for GeneSpect is usually less than 1 hour, around 40 to 45 minutes. And for the COBAs, it takes 1 to 2 hours. We also can use the enzyme-like ELISA test, and we also have the rapid diagnostics test, which can be also a very good point of care result for the clinicians. And then lastly, we have the next generation sequencing that provide detailed genetic data for tracking mutations and understanding viral evolution. But as you can see here, the major gold standard that is recommended by WHO is the PCR. So any other test that want to be used, usually WHO recommend to validate it at country level, scaling it up. This here we are at the analytical phase, where we show a bit the summary of Mpox test by infection stage. As you can see, we have different infection stage, and there are different tests that can be used at different stages. For example, at early stage, the main samples that the main test is the PCR DNA detection. It can take up to 8 days after symptom onset, so it's very sensitive. And then the mid to late stage, we can use PCR also, but serology can be also used to detect antibodies, and this one is 10 to 14 days after infection. And at the last stage, which is the recovery stage, usually serology, the one that is used to ensure that there is viral clearance after treatment. Now, the post-analytical phase is also one major challenge that we have in our setting, how to improve it. Sorry, there is someone who didn't close his mic. Can you close it? The lab result interpretation is one of the key elements that need to be considered. And then secondly, the report that is sent to the clinician need to really have the minimum recommendations that will help track progression and a response to treatment. And then which tool can we use for data management? Integrated result electronic health report, or like in our setting, use the DHS2, the District Health Information System, to ensure secure and accessible data for ongoing monitoring and response. And then the quality assurance through review process is also very critical to make sure that we don't make any mistakes when we capture the data or print and send to the clinicians. And communication, that is very crucial also, because there is no need to test samples and leave the result at the lab without sending it back to the clinicians or to the surveillance team who requested the test. And that's usually what actually creates a lot of difficulties. What are the different improvement strategies that we can put in place really? Because I have taken you through the optimization process, what needs to be put in place from the sample collection to the result delivery at the lab level. But I think there is new strategies that can be put in place. So those future strategies should focus on integrating advanced technology, such as the use of mobile health application, or the electronic health record, or the DHS2 that I just talked about. This will help streamline data collection and accessibility. The mobile health application, for example, will help track health metrics, provide medical information, and facilitate also telemedicine consultation. The geospatial mapping tools also can be helped to track the spread of diseases. The artificial intelligence also can be used and sensors to enhance data accuracy and provide deeper insight into outbreak patients. So strengthening lab infrastructure also is also a strategy that needs to be put in place also to strengthen surveillance and diagnostics. First, upgrade lab facilities. Ensure the availability of the required equipment for diagnostic. We went through a list of tests that can be used for Mpox Diagnostics. We talk about PCR equipment, we talk about COBAS equipment, we talk also about gene experts. So those basic equipment need to be put in place to ensure that the lab can test on time, in real time. And implement also telemedicine to reach remote areas. Regular training and workshops for healthcare workers to ensure they are equipped with the latest knowledge and skills to handle emerging health challenges. You know that the turnover of staff in our settings is very high. Sometimes after training someone, you come back 6 months later, there is a new person. So regular training is really key to improve diagnostic. So in future conclusions should also emphasize the importance of real-time data sharing, because that's where we also have a lot of difficulty, and collaboration between different health organizations and governments. Now I'll take you through the last two slides to share with you the work that FHI actually is doing in Africa to enhance and improve Mpox diagnostic and surveillance.
Amy, can you wrap up because we are running out of the time?
Okay, this is the last two slides. Give me 1 minute, I'll go through them quickly. In DRC, for example, FHI's work close hardly with specimen transport to improve turnaround time, and also provide training for healthcare practitioners and procure PEE, etc., PPE to support the different settings. and also conducted awareness campaigns in local schools, etc. Same thing in Ghana, where FHI worked hard on community-based surveillance and provide training and capacity building. In Nigeria, FHI actually enhanced lab system and support the enhancement of national surveillance system. In Guinea, FHI actually has been instrumental in enhancing the country's health infrastructure. FHI developed an improved specimen referral by developing an integrated SRS using specimen referral using electronic tools to track the location and the temperature of the samples. But FHI also worked to strengthen national and subnational capacity to improve diagnostic network and lab systems for detecting priority pathogens. So this is my last slide, and thank you very much for this opportunity.
Thank you so much. That was terrific. So in interest of time, we're gonna regroup all the questions during the QA. So we're gonna move to the Dr. Emmanuel Agogo, who was originally the first speaker. So Emmanuel, the floor is yours. Put your camera and introduce yourself properly.
Give me a minute as I try to share this.
Yeah.
Share my screen. Okay. Right. I hope you can see my screen clearly.
Yeah.
Right. All right. So apologies. There was some logistics reason challenges joining earlier. I'll be running through a slide deck that explains a few things. First of all, basically running through the state of diagnostics based on the work that FIND is doing. And then I will share just the highlights of some other work that we did evaluating some diagnostics earlier in the year over a project that was run previously. So I work for FIND. FIND is Foundation for Innovative Diagnostics. We work as a product diagnostic partner. And essentially what we do is work with manufacturers and as well as researchers to look at the state of diagnostics and make them available. At the beginning of the declaration, our team worked on doing a landscape, and that required looking at all the tests available globally from various companies, wherever they are in the world, that have tests that are available for Mpox diagnosis. And we identified 155 companies, and this is the distribution of where these companies are located. You can see that at the time, we didn't find any located in, just very few located on the continent. There was an evaluation done in 2020, 2023 to address during the FACE that was declared in 2022, 2023. A repeat evaluation of the landscape showed that we now have over 230 tests which came into an improvement of 130 that came into the market from the time that the first FACE was declared. And the breakdown is really that the majority of tests, as you can see, are molecular tests, over 125. And FIND, we work really to focus on availability of near point of care tests and rapid diagnostic tests. And you can see that the landscape was very limited antigen tests available. A further breakdown looking at those on the market and then breaking down my research use only, but focusing on the RDT test showed that the majority of tests were lateral flow assays. Only about 25 had gotten some kind of regulatory achievement. Mind you, these are regulatory CE, IVD, or FDA or MHRA, but not WHO approval. And this is the profile of the antigen targets for the antigen test. The majority are unknown. And there were a few ELISA tests that were research only. And like I've highlighted earlier, the majority of tests remain tests that are available for lab-based testing and not near point of care tests or true point of care tests. And this highlights the challenge and this problem that FHI mentioned that they are helping to solve in terms of sample transport. If you have a test through point of care or near point of care of tests available, then that eliminates that bottleneck in getting tests done for patients. And we did a quick evaluation based on our tests to see which ones had claims, because obviously these tests have not been evaluated in the context of this current fake. And so which test showed promise or claimed ability to be able to identify clade 1B. And you can see that the regulatory status was very limited in terms of the tests. These are the data, self-reported data, as it were. This other piece really was looking at the point of care molecular tests on the market that also claimed clade 1B coverage at the time. Plus Life was the main one. And then the others, as you can see, a lot of them research use only, and the majority also don't have any regulatory approval. This is a clear challenge. Then just to quickly reflect on some new technologies that we saw when we were in the landscape, there are quite a few possibilities through and then some new approaches. So, for instance, you can see that Conti Pharma, which is an LFA technology, got regulatory approval in the DRC and may not have necessarily gotten all the other global approvals that we usually would see. Just to also describe, after that process, what we did was to go through a process of trying to develop what we called an RFP, a request for proposal. And the request for proposal was meant to have a situation where we will see which tests were available globally for us to evaluate. And so we opened up an RFP globally, molecular diagnostic tests, about 50 rapid diagnostic tests. And you can see the spread. Most tests came from China and India. That's where the majority of the manufacturers are located. So we went through a process of scoring these tests to look at the clinical evidence, the technical specifications, the business assessment matrix, and also the ability to align with these value PP, because I will speak very briefly to that later. The WHO have a target product profile for diagnostic tests, and we looked at how well these tests align with those. And based on that, we scored and identified about 10 tests, which we want to move based on availability of funds and some addressing some technical internal issues. Really would like to do some evaluation to generate clinical data that evaluates the ability of these tests to meet the WHO TPP in terms of the sensitivity, specificity, and the CT values at which we get the optimum results. Same thing with the molecular point of care device tests as well. As you can see, we had Gene2Me, Plus Life, and a few others which we are already working in the TP space. Can you hear me? Can you hear me?
Yes, please.
Yeah.
Okay. Yes, please.
Okay. Continue.
Okay, right. So, so our next stage of work is really to identify the next phase of tests and make sure that we have the tests available and are able to evaluate them. And we plan to undertake a clinical and analytical evaluations. So I will take a few minutes to run through when we say, oh, there's a person in the background who's talking. Bitambile, please mute your mic. So what do we mean when we want to say we want to do an evaluation? Essentially, with the evaluation, the process that we do is to take a clinical evaluation within the lab in the field, as well as an analytical evaluation to evaluate within the lab space with contrived samples, in silico samples, or with stored samples.
Emmanuel, we seem to have lost you. Could you maybe shut your camera to enhance the efficiency of your... Yeah, we have lost Emmanuel. Hopefully he's going to reconnect quickly. So while he's reconnecting, just amazing to see all the really candidate tests in hundreds. I was so amazed, mostly from China and India. So this is going to be a very helpful discussion. Here he is back.
Yeah,
hi, Emmanuel. We lost you a little bit. I'm not sure your internet doesn't seem to be strong, so maybe you can shut down your camera and...
Yes, I'll do that. Okay. Okay. So if you can still hear me, like I mentioned earlier, there is a target product profile that was developed by the WHO. And for now, testing is based on PCR using lesion samples. That's the standard. And like it was shared earlier, the infrastructural issues make it difficult for all the people who need tests to receive the test. So I just want to share a few pieces of information from an evaluation that our colleagues did, that we did on a group of 5 tests. This was, we did that last year before the current declaration of the FEC. And essentially we did an evaluation just to give you a taster of what the performance was for Cepheid and for SD biosensor, which were point of care NAT tests. And then for RDT tests, you know, the biotech, Assure, and the SD biosensor antigen tests. So we picked these 5 tests from assessed from another call that was made in 2002, and this evaluation was done 2002, 2023, so 2022 into 2023, and the results were available from early this year. I will share links to preprints of the publication. So this was where the evaluations were done in Bangui, in DRC, with clinical evaluations done in Liverpool. And I will be very brief. I will run very quickly through this. But essentially, this is a breakdown of the samples that were used to evaluate the test. In DRC, 68. In the UK, type clade 1, assumed to be clade 1A in DRC, clade 2 in the UK, and then the combined samples for the clinical evaluations were 79 samples. Just to flag that these were clade 1A samples, although based on assumption, because they did not really have sequencing done, but we assumed based on the prevailing circulation at the time. So the specimen times, we did lesion and we did oropharyngeal swabs, and there was a range of CT values available across both locations. And the performance, as you can see, generally what we did, the performance was clear that the molecular tests have higher sensitivity based to the antigen tests. This was very clear. For all of them, specificity was fairly high, especially for the antigen tests, but the sensitivity was not ideal at all. And if you look at the sensitivity of the point of care in DRC, it was lower than the combined analysis. So this is what we found when you compare it with the overall analysis that was done. And in terms of the UK, this is the sensitivity of the results that we got from the UK. And you can see that in terms of the antigen tests, the sensitivity was not ideal at all. For Cepheid, sensitivity was high from the UK evaluations, but specificity again, where there was a challenge. So this just shows a summary of the slide of the results. Improved performance was generally seen at the lower CT values. This has something to do with what we think with the type of sample collected. Also with indications that perhaps the type of swab used and the time to evaluation of the tests, all those may have been factors. And in terms of sensitivity, the time of sample collection had an impact on the specificity and the sensitivity of the results. So generally speaking, high clinical sensitivity with point-of-care molecular tests compared with the antigen tests. So this is still not as based on those results, and that is why we wanted to do this second phase of evaluation based on another selection of RDTs. So far, RDTs are specific but not sensitive enough. But for the and therefore there were also limitations based on what we found in terms of the number of Mpox negative samples from the UAK cohort. And remember that this was done in late 2022. So our conclusion from that test, and this just lays the ground for the amount of work that still needs to be done for antigen tests and for the near point of care molecular tests to really make sure that the tests being rolled out say what is on the tin, so that we can be sure that we're rolling tests that are effective and useful. It's still a gap in the evaluation of these tests against, on the clinical, as for clinical evaluations, against clade 1 tests in terms of the performance for this particular outbreak going forward. Even though there are new tests on the market, what we'd like to do is make sure that these tests are properly evaluated. So these are, you can screenshot these. These are 2 preprints of the evaluations that were done by the colleagues in HUG and in Liverpool School of Tropical Medicine. So I'll stop there, and this is also an acknowledgement of our team at FIND that have been working tirelessly since the declaration of the FEC and the FACS. So thank you so much for listening. Happy to take questions.
Yeah, thank you so much, Emmanuel. This was really high level, really very clear and very updated and detailed, the pipeline and the pros and cons where we are. My quick question before we have 10 minutes left for the discussion, my quick question, what the priority to move the field ahead? What the next priority from FIND perspective? Really, this is really, I was amazed just the 100 number of tests, mostly from China and India, but really very few have been validated. Is my assessment correct?
Correct. I mean, many, especially for RDTs and for the near point of care molecular tests, there were none really on the continent. There were no major ones seen. I mean, there was Revital that we looked at, and I can show a link to if people want to have a look in terms of specific tests, I can put a link to the directory. This data is publicly available. You will see that even the tests that were not recently declared to be available on the continent or manufactured on the continent are more PCR tests and not your RDTs and the near point of care molecular tests that can really solve this problem of taking the test to the patient, to the community, and testing at the community level like we saw for COVID. So this is a huge challenge that needs to be still addressed.
Thank you very much. So let's open for the floor quickly. So I will first direct a quick comment either of those 2 talks, excellent talks. I would like to ask Dr. Dipanjan Pan, who's one of the expert in diagnostic for University of Pennsylvania, to make a comment or question.
Yeah, thank you, Dr. Nachega. I think this is great, fascinating talks. A quick question, does any of these rapid tests distinguish between clade 1 and 2?
Emmanuel?
So, yeah, so actually, like I said, the tests as we have right now are based on claims. We have not been able to do the evaluation against clade 1B. Even the gene expert test, the readout that you get with the gene expert test is orthopox positive and clade 2 positive. So for clade 1 positive tests, it is by inference that when you have a readout that says autopox positive and negative for clade 2, it's by that inference that the Cepheid test is read as a clade as a clade 1 positive test. So for the RDTs as well, so far we've not seen any that reads out clade 1, clade 2 specifically. But like I said, we're really trying to do the evaluation. And even if there were claims to that effect, we have not done any independent evaluations that confirm the claims that they have on the based on the IFUs and the manufacturer's information, etc.
Great, thank you.
AB, any question, comment? Or we're gonna go to the Sophie has a question in the chat.
Sorry, my mic was closed. Yeah, no, thank you very much. I think this is a great presentation. The comment is that we observe the same trend when we are having the COVID pandemic. We have tens of lot of tests coming from the same countries, and but unfortunately the sensitivity was as low as he just showed us. So definitely, like I said in my presentation, even though there are tools, WHO always recommend to validate or evaluate those new tests before using at country level. Point of care testing in our setting, like I demonstrated with the challenge with sample transport, will be a very good tool really to bring at facility level. But unfortunately, we are facing a lot of difficulties with the quality, the sensitivity, and the specificity.
Thank you. Sophie, do you want to address your question?
Thank you. This was a question for Emmanuel. That was a great presentation. Thank you. I was just wondering if the swabs which were used for the rapid diagnostic tests were stored in viral transport media, or were the swabs run sort of at the point of collection with the running buffer of the RDT?
Right, so that's a great question, Sophie. And that's one problem that we, in the next series of evaluations that we want to do, we want to address that. So the tests were run on samples stored in VTM for these first evaluations that I reported from the data that we did from 2022-23. And because of that, this next phase of evaluations that we are hoping funding and all other complications barring the once these are solved, that we will run another set of evaluations that will include two arms where we're looking at the point of care diagnostics using the VTMs, using samples stored in VTMs, and then for the RDTs using dry swabs collected simultaneously and run with the buffer from the tests. So that's the approach to really remove that bottleneck and possibly that confounder in the results that we're seeing. I hope that answers the question.
Yeah, that's great. Thanks, Emmanuel. And just to follow up to that then, will you be launching another sort of EOI for tests that may be developed sort of since 2022?
No, that's what we just did actually. So I've shared, I'll put in the chat like I said, we've updated our test directory. So currently we have a test directory that is up to date as at, August, October. We've done, and we are keeping an eye on tests right now. And the test directory, and I will put it a link in the chat for you to look at it. It's open source, and you can see which tests are available, where they are from, who the manufacturers are. Of course, some of the information is proprietary, and so those are hidden perhaps behind a firewall. However, you can really browse the directory and get all the key information that you will need regarding any of the tests. And if you need further information, obviously feel free to reach out, and we're happy to provide further information as well.
That's great. Thanks so much, Manuel.
Okay.
Yeah. So maybe last question, or one of the last question, Prof. Leonid Irenge from DRC.
Thank you, Professor Nachega, for your for giving me the floor. Thank you. The question I would like to ask is one question you raised a few minutes ago. So when you look at all these tests that come from India, from China, almost nothing from Africa. What does it mean for you and for all of us? What can we do to overcome these hurdles, which kind of condemns Africa, to just depend all the time from other countries or the continents, even for a disease which is specifically a disease from Africa? What do you think? What can we do?
That is a provoking question. So, Emmanuel, you want to tackle that, or?
That's the
This person on research and development, R&D from Africa.
Yeah, I think that is the million-dollar question, right? And that's where Jane, as you remember, this application for funding was done for the Mpox Research Consortium, and the fact that and I will also put in the chat one piece of work that our team has done. We've called it the Pathogen Diagnostic Readiness Index, and essentially it is a tool with which we have tried to map all the tests that are available for 20 pathogens groups, and try to understand what's available globally for them. And you will see that for this group of pathogens that are important to Africa, in terms of availability of tests, it's a dismal picture, right? And it starts from not just the issues with funding for it, but even the research people, the interest in the research, the high level R&D, and the collection of samples and maintaining of biobanks that help you with test development, as well as down to basic things as government interest in ensuring that even when these tests are developed, that they will purchase. Because one disincentive for many manufacturers is that there is no pipeline downstream. We've developed these tests and no one is purchasing. Also because we've not really prioritized diagnostics as a central part of our healthcare infrastructure. I think it's a complex issue, but it needs a broad-based response. Thank you. I've put a link for the PDXRI in the chat. I'm happy for you to, also another resource for you to look at.
Thank you so much. Dr. Dapan?
Yeah, so I just want to make a quick comment that I think this problem is kind of a global, and I'm not quite sure if there is any a concerted effort is being put for even from the US. I haven't seen any funding announcement coming for developing monkeypox tests, mpox tests. So it's just not for Africa. I think it is kind of, the problem is kind of a global.
Yeah, Emmanuel, a quick reaction on that answer.
Okay. And that response is spot on. One of the other pieces of work that we've been working on has been the 100-day mission for diagnostics, which is really trying to approach this issue of outbreaks and of disease-prone diseases in a way that is more holistic. And I can assure you that we've not received any funding so far to implement the activities, whether it's a high-level engagement with researchers, as a way of implementing for instance, the WHO has released this new pathogen family approach to tackle outbreaks and epidemics. That also hasn't been properly addressed. And we need a collective global effort that can respond to the small fires as we think about the big disease X. Back to you. Back to you, Jen. Is he still there?
Yeah. So,
okay.
So that's great. I think we are on time. We're not gonna take more questions. This was really terrific. everyone have the contact of Emmanuel, Agogo, and Abby for more communication. I'm gonna follow up those discussion with the selected speaker through our MpoxReC consortium and AFREhealth. And we're gonna have another follow-up webinar on diagnostics sometime early next year. So thank you, everyone. This was really terrific. And this has been a recorded webinar, and the PDF of the slides that are eligible to share will be distributed. Thank you so much, everyone. And we'll be in touch.